delighted to have you all here today. My name is Mike Reed. I'm a member of faculty at the Institute for Global Health Sciences. This is Reimagining Global Health Conversations for Change. On behalf of my colleagues Naomi Baylor and Arista Janji, members of the UCSF Decolonizing Global Health Working Group, we want to welcome you to this session. If you're joining from another University of California campus, we extend a warm welcome to you as well. Thank you. And as a reminder, the goal of these sessions is to explore and discuss how and why global health needs to change by asking hard questions about the work that we do, how we're funded, and the extent to which our research, education, and programs perpetuates coloniality rather than advancing authentic global health equity. Every month, for the last 7 months and for the foreseeable future, we are inviting critical thinkers, leading academics to help us ask hard questions about our community. In what ways does global health education, research, and programs perpetuate asymmetries in power that exacerbate global health inequities? How does coloniality still manifest itself at the global level in terms of funding and governance of global health institutions? And finally, how do academic institutions like the University of California address the impact of colonization on the work that we do, both globally and locally? How can we be catalysts for new and more equitable models for academic global health? We are delighted to welcome today Dr. Cristian Montenegro to our group. Before I introduce Dr. Montenegro, or Cristian, a word on format. This week we're going to have a presentation for the first 30 minutes from Dr. Montenegro, and then we want to make this as discursive as possible. My colleague Arista will be moderating questions in the second half of the session. So feel free to tag Arista in the chat if you have a question or a comment for Cristian. And then in that second half, we'd love you to come off of mute and share your question or comment. But in this first half, if you could be reminded, just kindly place the mute on so that we can optimize the audio quality. So let me begin by introducing Dr. Montenegro, Cristian, to you, who is actually joining us from the other side of the planet today. So good evening, buenas noches, Cristian. Thank you for joining us today. Cristian is a qualitative researcher with a background in sociology and community psychology. His work broadly concentrates on the exchanges between health and democracy at the micro level, service user participation and engagement, but also at the macro level, health-related social movements, democratic transitions, healthcare policy, and human rights. And he's specifically interested in asking these kinds of questions in the global South. Cristian is a founding member of the Platform for Social Research in Mental Health in Latin America, PLASMA. He's on the editorial board of Critical Public Health and PLOS Global Public Health, and he is part of the Somatosphere Editorial Collaborative. Currently, he's a research fellow at the Wellcome Center for Cultures and Environments of Health.
No way!
Just a reminder,
Your class started.
No, I just have to. Maybe I'll make a pop. I don't think so. There's too many people. You're what? Oh yeah, you did.
I think you're mute now, Mike.
I feel like I'm a little. It's like I'm intruding.
Oh, I got muted there. Thank you. I was just saying, currently Cristian is a research fellow at the Wellcome Center for Cultures and Environments of Health at the University of Exeter, and is also a researcher at the nursing school at Pontificia, Universidad Católica de Chile. Hope I'm pronouncing that correctly. And as it's relevant to today's session, Cristian is also a researcher who is thinking critically about global health in general and global health education, in particular from the vantage point of Latin America, and also with the perspective of a social scientist. Cristian, we are delighted to have you here today. Welcome. Thank you for joining us. And I'll hand over the reins to you now to give your presentation.
Thank you very much, Mike. It's a pleasure to be here. I'm very glad about the invitation. I'm happy that there's people listening and willing to engage in these discussions. I'm happy that the UCSF is keeping this discussion alive and bringing different voices into it. I think it's very important to diversify the positions, the locations, the perspectives within this larger debate on decolonizing global health. Before I share some slides, I just want to maybe complement some of what Mike just said. I think it's important to understand kind of the trajectories of people and how do we get into this debate in a way. So I'm Chilean, come from Latin America. I did my master's and PhD in the UK. I've worked in the Ministry of Health in Chile, so I've worked in policy. I've also worked in a nursing school. So I kind of have a foot between kind of the social sciences and the medical sciences, and at the same time between Latin America and Europe in a way. I've been in and out of Chile, and now that after COVID, it's kind of hard to say where you are in a way, because I'm doing so many things with Chile at the moment and also in the UK. So the idea of being based somewhere doesn't seem to be the same now. And for me, it's important to express that. So I think that my perspective, my point of view about global health is pretty much related to the fact of being a migrant, of being kind of someone that is moving around institutions, moving around disciplines for a while. I've been working a lot on mental health. That's kind of my main concern. And within mental health, I work a lot on service users involvement, the experience of receiving care, receiving services in different parts of the world. So that's also something that I think you should consider in listening to my presentation. So I'm going to share some slides now. Okay. All right, so this presentation is based on some ideas that I've been collecting for a while on global health, basically asking myself, like, why should we train people on global health when we still have so many public health problems here? So I'm trying to introduce kind of a distinction here and trying to convey the meaning that global health has when one works in a country in the global south, like Chile or like Argentina or like Brazil, where public health concerns are still very important and where one needs to deal with this question in a way and take it seriously. And then it says global health from and in the south. So, so for this presentation, basically, I'm relying on the wealth of discussions and proposals that have come to be organized around the idea of decolonizing global health. That means that I'm not starting from zero. I'm not proposing foundational concepts or alternative definitions. I'm not presenting a radically original take on the issue. I'm accepting that we have a problem, that global health is filled with asymmetries and inequities, and that we need to address, and that academic institutions across the world are key agents in this transformation. The more specific concern that has moved me over recent years are the local reverberations, to put in a name, like the local difference that these discussions have. How do we, as academics and researchers working in or with global health, global South institutions, engage in this discussion in order to make a difference at the local level? That would be my main concern. Because although paradoxically, there is a risk that the discussion around decolonization only makes sense within the global north as an internal dispute or controversy, mobilizing positions, opening debates, and refreshing the field, but with little impact in those places and on those people that matter the most. What, say, Abimbola calls the activists and plumbers in the global south.
No, I don't.
So I don't want to base this intervention purely on ideas and debates. Instead, I want to talk about an initiative directly linked to this problem. I'll start by talking about and supplementing some of the points that Marcela Gonzalez, Margarita Bernales, and myself made in an editorial published last year in Critical Public Health called, you can see it there, Teaching Global Health from the South, Challenges and Proposals, that was born out of the challenge of creating a global health undergraduate and postgraduate course based at the School of Nursing of Pontificia Universidad Católica de Chile. And you said it very well, Mike. So, but first, to situate this talk, I would like to take some time to talk about the role that universities play in global health. Their role in the existence and the continuity of what we call global health. More generally, I want to talk about how certain geographically circumscribed entities kind of transcend their spatial constraints to develop an identity and a mode of approaching their objects that one could call global. The ability to take off from the limitations of proximity and the weight of being somewhere. One could ask, how can some institutions and their actions cut through the pull of locality and proximity? In my view, you need several conditions. One is some form of unidirectional connectivity. This means a historical legacy of domination or intervention modeled around colonialism or imperialism that created chains of command that span through the globe, producing a high degree of extractivist unidirectional connectivity between a few centers and many local nodes. One could name British colonial rule, the USA intervention in the Cold War, etc. From Latin America, I usually mention the Cold War because that's kind of the matrix of international intervention that had a stronger, one could say, legacy in this part of the globe. Then you need what I call epidemiological transition and epistemic othering. This same legacy produced an unprecedented accumulation of wealth that allowed scientific development, clinical advances, large-scale sanitation, public health interventions. Together with other contextual elements, this pushed an epidemiological transition that we know very well, that created a split between northern and southern patterns of disease. So this produced a split between local public health and global health, or what King and Koski call public health somewhere else as a definition of global health. This split is, of course, real. Different countries and regions do differ in terms of types of disease and availability of treatments. Nonetheless, if we consider the first legacy, that of intense unidirectional connectivity, global health, or the public health of other places, becomes an area of intellectual and practical development for institutions in the global north, thus eliminating the pull of locality and proximity. So universities participate in this kind of anti-gravity, in this ability to move globally. They do not just make use of these legacies and opportunities, but constantly invest and rely on the ability to take off, to observe and intervene at a distance. This, of course, attracts talent, resources, citations, influence, prestige. But the problem is that this anti-gravity is premised, and I think the whole discussion on decolonization points to this. This anti-gravity is premised on unidirectional connectivities and an epistemic othering that fails to acknowledge the plurality of bodies and ways of being, as theorized by Clara Afun Avegbulu and Obemimosi Adegbulu recently in a BMJ editorial. So after this, I'm trying to kind of theorize a little bit how some institutions are able to present themselves as global. And we had to ask this question precisely because we wanted to be a university in the South trying to produce a global health program. So these questions kind of became relevant for us in a way. So in 2019, a team of academics in Chile met to consider the possibility of developing global health teaching materials in a place that does not accomplish premise 1 or premise 2 that I just mentioned. That means a place that is mostly connected with dominant centers of power, but that has limited south-south connectivity. And that is still and will continue to deal with complex, widespread public health problems internally. Precisely because our context was so different, is that we wanted to avoid simply copying the formulas around global health available elsewhere. We wanted to create a more close to the ground, locally oriented approach. So the key question for us was, what sort of knowledge about global health could make a difference at the local level? And conversely, how do we approach our local health problems and solutions in a way that could matter elsewhere? To put it differently, how do we take part in current discussions around global health in ways that remain connected and relevant to local problems and solutions? I know that we don't have an answer, but we do have a degree of clarity regarding the challenges we faced. And I do believe that these questions and challenges are also relevant for universities and research centers in the global north that have an honest intention to decolonize their own curriculum. So the first challenge that we face in kind of a democratizing global health would be the hegemony of the English language. Since, as we know, most of the global health literature is written in English, not only this, but most global health programs are offered in English, even in non-English speaking countries. So this acts as a barrier for accessing further training, a barrier that goes beyond academia, with local health workers, policymakers, and government officials having limited opportunities to inform their practice with emerging or comparative evidence. A closely related challenge is the biomedical predominance within the field, a tendency that informs, and it's informed by global health. The perspectives of sociology, anthropology, historiography, or political science, key for understanding the role of local specificities on health and illness, are still marginal. If discrete metrics and forms of quantification purely based on biological phenomena are the main tools we use to make sense of the world, then we will struggle to understand and address the cultural, historical, and political conditions that shape disease. Power will be hard to grasp, including the forms of power that shape our own professional identities and our visions of what needs to be done in the field. Finally, the most obvious and at the same time more pernicious challenge that teaching global health from the South faces is to overcome the idea that it doesn't make sense to teach global health in the South. The idea that thinking and acting upon global health in global terms makes more sense in certain places than in others. To recycle George Orwell's famous phrase, we are all part of the globe, but some places are more global than others. Why do I insist on this? Because we've been faced with these questions asked directly by our colleagues in Chile. So why should we train people on global health when we still have so many public health problems here? Why not just public health? I think this is an important question. This kind of a sense of strangeness that we created, I think that there is something there. Our first attempt at a reply, and this may be very specific to Chile and Latin America, is that we are already being the object of powerful global agendas around trade deals or patents and the manufacturing of essential medicines, for example. And probably after COVID, this is more evident than ever. We are subjected to global geopolitical determinations of health and disease at the local level, and therefore we need to situate our local public health efforts while carefully attending to global phenomena. But a further response can be given. What we do locally can and should have an impact elsewhere. We should be able to share information and practices with other countries. We should be able to compare our situation and launch regional and South-South collaborative endeavors around health. Maybe we could conceptualize this by saying that in terms of health, disease, healthcare distribution, and accessibility, places like Chile or Nigeria or Pakistan or Malaysia need to move from being objects of global health to become agents of global health. This transition should be the focus of global health training in such places and in the global South at large. And this is clearly a different global health from the one that we already know. As we argue in our 2020 piece, crafting a Southern view and practice of global health requires two main analytical movements. One movement places the focus on local conditions and sociocultural foundations of health and illness, bringing local history to the center and drawing extensively on the social sciences. The other movement reflexively considers the geopolitical imbalances that are at the core of the global health enterprise to undo them in the act of teaching and training. So I think this was our main, I would say, like goal when we were having this discussion. How does teaching can become an act of decolonization in a way? Because in global health, the act of teaching is not, in my view, adequately considered as a tool of transformation. Because it's a very kind of microscopic act. It's something that happens in a classroom or something that happens in an interaction in a way. It doesn't seem that large or that structural. But we thought that the act of teaching, the way you teach, it's important to transform global health in this case. So this double reflexive approach can aid students and academics to observe from an ethical stance their professional practice, tracing the local and global dynamics at play in the emergence and distribution of health and disease. But at the same time, and maybe more importantly, we need a moment of affirmation. So this is not just analytical in a way. This moment of affirmation, whose scenario should be the global South in a way. Self-affirmation, or the affirmation of our global role, of the value of our practices, the value of our ideas and intellectual traditions. So only this act of self-affirmation can engender reciprocity and dialogue. Thanks.
Thank you so much, Cristian, for that very insightful presentation. I think the transition that you mentioned from being the object to the agent is especially interesting and not one that we've heard other speakers talk about before. So that was great to hear. We have a few questions that we've prepared and that have come in from registrants. And so we wanted to start off with one related to the Global South versus the Global North. So you've talked a lot about how institutions in the Global South can kind of approach global health and align it with local health objectives and sort of priorities. What would be your guidance or thoughts for universities such as UCSF that are based in the Global North? How can they kind of prioritize local health objectives and kind of localized priorities in a more meaningful and kind of less patronizing way, in a way that essentially prioritizes local knowledge?
Yeah, I think this is a very important question, and with some colleagues we've been trying to kind of collect some knowledge. Basically, what we want to do is to know the experience of a kind of actual collaboration between South and the North in global health research, to learn kind of best practice around collaboration, basically. So, well, I think that the answer in a way depends on the level that you're working at. For example, in terms of research projects that sometimes have like different nodes in different countries. I think that at least in global mental health, which is the field that I know the most, I mean, there is like a basic need to understand context so that projects won't fail. So there's actually like a pragmatic reason why to involve people involve local people, involve local teams, involve local knowledges, so that projects won't fail and they can be sustainable. So there is a pragmatic dimension to that. But in terms of, I think that opening up spaces of interaction is key, and trying to be aware of how these things are being discussed in different places. Because I think that the risk is that this becomes kind of a conversation between kind of Europe and the USA in a way, which is an interesting and powerful conversation, and I think it's very useful. But at the same time, it's not that clear how this has some effect at the local level. That's precisely what moved me to kind of engage in this, is to try to keep these two worlds connected somehow, and not isolated from one another, like each one has its own issues and its own problems. So yeah, I think I'm kind of repeating what I said in the presentation, but it's kind of general. But I think we need to be creating how to keep these two worlds connected and talking with each other. And that goes from like developing maybe bilingual special issues in key journals. I think journals are very important in this task as well, because if we want to do communication between geographies, that communication needs to go through somewhere, and journals are the main space for that communication to happen. So translation and bilingualism or trilingualism, I think, are key to foster this communication.
Thank you. Yes, and I think another question that has just come in that's related is what else can be done about kind of challenging the hegemony of the English language and how that perpetuates asymmetry. So I know you mentioned translation of journals, of materials, of meetings and recordings and sessions and things like that. Is there anything else that you can think of that can be done to kind of challenge English as the dominant language?
Well, this is always like an interesting point, I think, and I'd like to also maybe to make a little to reflect a little bit upon this. I think that in my case, for example, when I write in English, I do it because I know that my audience will grow, basically, and my audience is not just people in the USA or people in the UK. Actually, what I'm thinking about is people in Japan or people in China or people in many parts of the world that use English as a medium. So it's kind of a paradox, because in order to diversify your links in a way, in order to diversify even your worldview, you need some medium, and for good or for bad, English is the medium. But what I want to say is that when we use English, we also do it to open up connections between parts of the world in a way, beyond the English-speaking world, if that makes sense. Now, I think that I've been involved in some attempts to do, for example, bilingual issues in journals or bilingual journals. I think that the issue is that due to the sort of economic life of journals, any addition to the current load is kind of is too big of a burden for journals at the moment. So you need really to kind of you need some investment to really create the kind of teams with the kind of time to work on this and to be able to translate or to be able to accept submissions in different languages. It is a different sort of way of working that I think that the journal complex, in a sense, is not very prepared to do, particularly the most impactful journals. So I think that in that case, you need kind of a vision, from some maybe academic centers that would kind of create a sustainable multilingual journal, because at the moment you don't see that, and given the economic constraints, it's hard to see that.
Thank you. Yeah, and I think another interesting point that one of our registrants had brought up prior to this session is that language isn't the only barrier that people face in joining these discussions. So what are some meaningful and effective ways to empower actors, researchers, academics, community members from the Global South participating in these conversations?
Yeah, I think that I can tell, like, by my own experience, I think that for me, kind of some questions started to form in the back of my mind whenever I listen to kind of a global health and global mental health, because I thought, okay, am I part of this? Like, is the research that I do back in Chile or with my Brazilian colleagues part of global health? Could we publish this in a global health journal? Stuff like that. Maybe out of my own insecurities, in a sense, came questions. So insecurities sometimes are powerful because they are based on something, like they're based on real concerns. And in my case, I kind of exploited those concerns to try to and then I remember, I think something very powerful for me was reading Seye Abimbola's work on the foreign gaze, because I don't know if people has read that. I would highly recommend that, because in a way that is kind of it gives voice to this to this local perspective and how it fits or it doesn't in the global health conversation. And most than that is like an invitation to make things matter at the global level, to make the local matter at the global level. So sorry. So I think that there are strong invitations to take us seriously in the global South, to take the things we do seriously, and to frame them not just to fit into kind of a specific remit of a journal, but because they're truly innovative or they're truly important and powerful.
Thank you. Yeah, I think we have a question that just came in from Priscilla. Priscilla, would you like to unmute yourself and ask your question directly?
Hello. I just wanted to ask, what are some commodifications in health that you have seen or heard about in South America?
Can I ask, what do you mean by commodification? I don't think if I understand correctly.
Just like anything that you have heard about that violates the values of bioethics.
Of ethics? Maybe you can give me an example of the situations that you are pointing at?
Maybe like in like a patient and doctor, like their type of like relationship, and like if there's like any like the cost of insurance and all of that, like how is it different from here in like North America?
Okay, yeah, I think I understand. So, well, I mean, in a way, the health system in Chile is highly privatized, and we have a very strong split between a public system and a private system. And that, of course, creates lots of distortions in a way, particularly because most of the medical professionals will work in both systems, and but the difference in quality and the difference in approach is very real, is very noticeable. So as soon as people have some money to pay for the private service, they will move into the private service. And that kind of gives a lack of sustainability to the public system and makes it like permanently, one would say, like in like low quality in a way. I don't know if that kind of answers your question.
Yes, it did perfectly. Thank you.
Thank you.
Great. So I think you had mentioned the two approaches in educational and academic institutions in the Global South, the analytical and the affirmative, and how those both need to be kind of prioritized within learning and teaching. I was wondering if you could elaborate a little bit more on that and kind of explain how teaching and learning can be a mechanism to undo the geopolitical power imbalances that we see in maintaining global health. It seems like a lot of the times the partnerships and initiatives that we enact and that we pursue just kind of serve to perpetuate power asymmetry. So how can we kind of go against that norm using the frameworks that you've suggested?
Yeah, so I think that this kind of starts when you kind of conceive a student in your mind as a teacher, you know, and you kind of conceive the things that you think will be attractive and powerful and engaging for him. And in our case, we all, the team that was working around this, we all came from the social sciences, and we worked on health, but as social scientists. So we thought, okay, actually like understanding how health and disease is determined by global forces is already empowering in a way. It already pushed you to kind of see your area of practice as beyond the clinic, in a sense, and even as beyond the country to a certain extent. So of course, you as a teacher in a program, there's so much you can do. Like you can present a certain background, you can explain certain causality, and you can make like an invitation to address this. But of course, you won't have all the tools or all the resources to help people actually engage in these things in the real world. And probably one of the things that happened, and this is also part of the story, is that kind of global institutions are headquartered in only in some places of the world. So even the proximity of those global institutions makes a difference. You know, I think that one of the things that happen in places like Chile or places like Argentina or Peru is that we are too kind of orientated to our own local concerns. And that is okay. Like I won't challenge that. I think it makes sense. You know, you actually engage in studying health because you are worried about the things that happen close to you. So that's for us kind of the question was, okay, but the things that happen locally have kind of a global roots, and we should at least understand those roots, those dynamics in the best possible way, or else you will be frustrated if you just focus, and if the nation is kind of your only framework, you will be frustrated at all the things that you cannot do nothing about, you know, unless you change in some way some international imbalances. So I think this is also part of the global, the decolonization conversation.
Cristian, if I may jump in, your perspectives are very illuminating, and I have a question for you, but I may go on a slight tangent. When you and I connected before, you told me, you know, some of your research is exploring the role of activism and protests in health. And I'd love to kind of have you reflect on a potential role for activism and protest in the global health space. But to tie that back to the conversation today, you use this lovely metaphor of anti-gravity, you know, which I think I'm interpreting as, you know, the fact that high-income country global health endeavors can happen outside of a framework where people are accountable at the local level in other countries for the actions that or the priorities that they're shaping. And I'm curious if you know, how we address that anti-gravity and whether there is a role for protest or activism. You know, I'd love to kind of tap into your thoughts on that.
Yeah, thank you for that question. So Yeah. Actually, yes. At the moment, I'm starting a new project on activism and protest, and basically what I'm trying to understand is the development of medical brigades in the context of protest. That means the development of kind of a voluntary healthcare actions as a response to police brutality. I'm looking at different countries, and you see kind of different traditions. And in the USA, you have a tradition of kind of street medics accompanying protesters and being aware and giving care. You have something different in Europe, in France, you have something different in Chile. But I think that kind of my concern there is how you see kind of a lack of even a protest is not like a medically defined scenario in a way, as for example human like natural disasters or areas of conflict or areas of displacement, where you have even kind of a certain terminology, a certain set of specific knowledge, and certain bodies as well, like the Red Cross or others, or MSF or others. But in the case of protests, although they are increasingly common and highly expected, and although they do a lot of harm to protesters, even death, they don't emerge as the scenario of kind of a formal medical intervention in a way. And the medical intervention comes from the protesters themselves. And this is the same in different parts of the world. So you see kind of a in a way, grassroots shared response that is not organized by WHO or by any kind of global organization. It's just there. It's kind of a part of the emotion. It's part of the reaction. But if you look at it closely, it's very technical. It's very similar to kind of a rescue medicine, but with no coordination, with no communication, very informal. So I don't know. I think that for me, the interesting thing is how these things emerge at the same time in a very similar manner in different parts of the world that are not connected. Now, particularly in Europe, you do have protests that kind of address kind of a global powers, you know, and the G8 meetings, for example, are usually accompanied by a protest. The same has happened in the USA, and some of the most violent protests in history have been premised in kind of putting a message out for these powerful institutions in a way, and trying to use this space of visibility, you know, and health, it's an integral part of that injustice in a way, because of the effects that this macro decision have on the environment, on the global warming, and eventually on health as well. So I don't know if that answered your question, but I'm kind of talking about my own interest in how they connect to global health in a way.
So and maybe the second thing is not entirely relevant then, but this issue of anti-gravity, the fact, you know, and the lack of accountability for you know, the work that the priorities that academic global health institutions in the global north set, and the unidirectionality that you spoke to. How can we address that? How can we give gravity to academic institutions like UCSF so that we are beholden to our partners in a more substantive way?
Yeah, I think that kind of having a degree of receptivity to the priorities that local institutions already have, that the priorities that already organize local action, you know, instead of kind of developing kind of a cutting edge intervention in the USA and then trying to partner out in order to move that, you know, into different places of the world. I mean, it's not that is wrong. You know, it's not that it's useless. On the contrary, sometimes it is important, but that should be also combined with a receptivity to the local priorities, and not only to the local priorities in terms of need, but also to the local innovations, you know, to the things that are being also explored, also created at the local level. And then you could make some form of exchange, like a more egalitarian sort of interaction with institutions and with demands. And then you will be, in a way, your presence will have more weight in those places, because you are working with teams that are already there, that are accountable in those places, that will stay there and be sustainable there, and you will help them out in a way. So I think that the way you define the interaction and the collaboration is key. It's not just to kind of find markets in a way for your own interventions, but to find partners to create stuff together in a way. I know this sounds very kind of abstract maybe, but that would be one way, I think.
Thank you. It looks like we have a couple of hands raised in the audience. I'm going to turn it over to Sebastian to ask his question.
Right. Thank you. And thank you for this wonderful presentation, Cristian. I really enjoyed it. One of the arguments that I'm attracted to the most, which you elaborated, and if I understood correctly, is to recapture, if you will, the local within discussions of global health. And that actually makes me wonder if perhaps this idea of decolonizing global health, it sounds more like a contradiction rather than a potential future research agenda. And what I mean by that is that when we talk about colonialism in Latin America or elsewhere, we really are talking about a view from nowhere in the sense of Donna Haraway's situated epistemology. So the generation of knowledge that arises from Europe in the case of Latin American colonialism, but is presented as universal knowledge, as global knowledge. That's what she means with the view from nowhere. And then it's being imposed in Latin America as, again, universal knowledge, right? So if you try to recapture, or if you try to reinstate the local within the global, it seems to me that it changes the definition of global health. It's no longer global health in the sense of perhaps, you know, this international health of the 20th century, or maybe even colonial health of the 19th century. It becomes something different. So I suppose my question more concretely is whether we need to redefine what global health actually means in order for it to move more towards this idea of decolonizing in the way that you're presenting. I wonder if there's a new definition, or if you see global health more as in, I don't know, in another way that perhaps I'm not understanding concretely. So yeah, thanks.
Thank you, Sebastian. Excellent question and very important. I think that to answer to this, I would kind of recall a conversation that I had a while ago about the legal system. So why am I talking about the legal system? Because when you talk about the legal system, you don't assume, you assume diversity immediately. You know that each country has its own legal traditions, you know. You cannot project kind of a clean, unobtrusive, kind of a global legal definition or legal framework. Kind of legality and the law is so connected with culture, so connected with history. And in that conversation, I made the question, so what happens if we imagine global health as we imagine kind of global law in a way? So, because if you want to move from one place to the other in terms of legal frameworks, you will have to learn in each country what its own kind of a legal history is. You will have to kind of start again. You will have to move slowly in a way. While in global health, because we have this kind of a inherited epistemology of a single humanity, of a single body, of a single biology that is the same everywhere, then it seems like we can just apply the same principles everywhere in the world. No? So maybe ways to reimagining would be to look at other fields, like other systems, anything that the legal system or literature, I don't know, these things that will force you to stop a little bit and to understand things again in each place. Maybe this is a way to, and I think that it exactly like you say, so global, like how to take out the universal from global, you know, like global is not the universal, it's something else. I think it's a challenge. I think it's an interesting discussion to keep having.
Thank you, Sebastian, for the great question, and Cristian for the response. It looks like we have another hand raised from Michael. Would you like to ask your question?
Sure. Cristian, fantastic presentation. Felicidades. There's so many places you can go with this discussion, and kudos to UCSF for your leadership in bringing us all together to talk about colonialism. Taking what you just said, Cristian, another level in terms of how can we learn from other things that are going on about us to inform what we're doing. Your metaphor of anti-gravity, I think, is a fantastic one because it's universal. Take UCSF, for example. UCSF is a center of power, right? Center of colonialism, one could say, in many ways, in which just the way that the institution itself reinforces colonial practices of one individual or one group or one department over another. And using money and many politics and many other ways in which those things happen. The same thing has happened and has been working. People are working through with what we call community-based participatory research, or working with communities. Right? Again, I mean, those people in the faculty at UCSF who go to the Mission, but now maybe go to Hunters Point. Other places like that to try to learn, but and move from continuing to dominate, instead to start to consider collaborating. It's a different way of approaching this universality of global health, which is local health, and it's another area where there's lots of lessons that are being learned, just as it is in this dichotomy between global health and just general public health. And I just wonder, if you sort of thought about that, and in terms of how these connections happen, so that we can have our own, action and political sort of tension, which is inevitable, since any actions in colonialism or anti-colonialism or anything related to that is going to be a threat to those in power. So there's a lot of interrelated things. I think there's lots of potential discussions and places to go, but I certainly appreciate any thoughts you have on these issues.
Thank you, Michael. That's great. And it's good that this is not like a answer and question. It's more like a conversation. I like that. There is something, there is a, you mentioned politics. I think that's important. It's never a word that I'm gonna run away from. On the contrary. And I think that the political aspect of this is that how to move from a conversation about a group of people to a conversation with people. And it is scary to make that transition, because when you open up to have those conversations with the people that have been kind of the objects of research, or the objects of charity or the objects of intervention, and suddenly you are faced with them. It's like you don't know what to expect in a way, and then things can move in any direction and turn kind of unpredictable in a way. And I think that's something that happens. And it's interesting, the connection between kind of a local work, community work, and then public health, and then global health, because it seems that they're very far away from each other. Like global health is something that happens kind of in the stratosphere. But actually, global health has a lot to learn from kind of a local organizing and local work, and the problems and the tensions that you face when you work with communities in a way. So I think, yeah, you need kind of this movement as well, this movement from levels, like this infusing the learnings from community work into global health. But yeah, I think that there is like a French philosopher, I don't remember his name, but he says that kind of a conversation is political when it is about who is supposed to have that conversation. Beyond the topics or the themes or the specific things, when the conversation is about who should be there to talk, then it is a political conversation. So decolonizing global health, it is a political conversation.
Thank you, Michael and Cristian. I have to apologize to those of you who have your hands up at the moment, since we are at time, unfortunately. But thank you so much again, Cristian, for your excellent presentation and for taking the time to answer all of our questions. I think it was great to get the questions from the audience and have some discussion at the end. And we're really grateful that you made the time for this discussion. So for those of you who are interested, our next session in the speaker series will happen on November 18th from 9 a.m. to 10 a.m. Pacific time. And we will send out the registration link and other details closer to the date, but stay tuned, and thank you so much for participating.
Thanks, it was great.
Thank you, Cristian. That was fantastic. Just echoing Arista's sentiments, really great to get your perspective. So thank you. Sorry we didn't get through everybody's questions, but great to get your insights.